Learn, jointly put together by the Ohio State University Center for Clinical and Translational Science and RACI at Nationwide Children's. The main goal of this webinar series is to connect behavioral health researchers, digital health researchers, and technology providers so we can learn from each other for clinicians and researchers to keep up with technology innovation, for technology provider to understand research needs, to brainstorm new ideas, to join force and collaboratively advance behavioral health research using digital methods, and accelerate digital health innovation to enable behavioral health research together. I'd like to thank Dr. Simon Lin, our Chief Research Information Officer, who came up with the webinar idea first. And sincere appreciation also goes to Dr. Cindy Gayhart, Director of our Center of Behavioral Health, and Samantha Sharp, Project Manager of CCTS at NCH, who did a lot of coordination and organizational work behind the scene for this webinar series. Last but not least, I'd like to thank Dr. Kat Houghton, CEO and founder of IllumiView, for kindly connecting us with several clinical researchers and hosting the next 4 webinars. IllumiView is one of the leading providers for ecological momentary assessment platforms. Quite a few clinical research studies have been successfully conducted using their EMA platform. Future webinars will include other digital health technology and platforms. We welcome any talk suggestion. Please feel free to enter your suggestion in the chat window or email Samantha, and we'll paste her email address in the chat window for you to use. And a few logistics before we get started. We're recording this webinar and we'll make the recording available to those who miss it. The presentation is around 35 to 40 minutes, which we will have, after which we'll have a 10-minute of Q&A session. And please hold your questions until the Q&A session. And you feel free to type in your question in the chat box. And once Q&A session starts, use the Zoom raise hand feature to ask your question. And we haven't set this webinar to grant continuing education credits. If you think that's important, we should do this for future webinars. Please add your comment in the chat box. Next webinar is on Tuesday, July 28th, with the same time slot from 12:30 to 1:30 with Dr. Andreas Schmidt from the Research Institute at American Time Diabetes Center in Germany. Now I'd like to welcome Dr. Kat Houghton, CEO and co-founder of IllumiView, to introduce our speaker for today.
Thank you, Young Wei. I appreciate your introduction. And thank you all for joining us. It's so great to see so many of you here. We're really excited to be working with Nationwide Children's Hospital and Ohio State to make this happen. And I'm very excited to introduce to you Dr. Nicole Nugent. She's at the Warren Alpert Medical School at Brown University. She's an associate professor in the departments of both pediatrics and psychiatry and human behavior there. She's also involved in the Bradley Hospital and Hasbro Children's Research Center there, where she serves as a Director of Resilience and Psychological Services, a role that informs research efforts that permit translation to intervention across diverse populations. And she's going to share some of that work with us today. She's been conducting programmatic research aimed at characterization of neurobiological and psychosocial influences during high-risk periods of stress and transition towards the goal of developing informed and novel secondary and tertiary interventions. Basically, she's doing some really exciting work that's helping a lot of people, and we're really appreciative that you're here, Nicole. So take it away. Thank you.
Thank you so much for such a great intro. I was saying earlier that it's unfortunate that I can't be here in person because I was very happy. I lived for a while in Ohio and did my undergrad training there and my grad training there, and worked in and lived in Grove City and also a couple other places in Columbus back in the day. So it's too bad I can't be there in person, but I'm really honored and excited to share with you some of the work that we have been doing. Today, I'm going to present one of my R1 projects that involve research related to digital health And this particular study is just now wrapping up. We're in the very end of our no-cost extension period. And so this data is actually about to be submitted. We're going to be able to finally start submitting some of these manuscripts. So you are getting this before it's published, but quite close to when that will be coming out. So to figure out how to advance my slides. Oh, that worked. Let's see. All right. So I have nothing to disclose. The focus of this particular research project is on suicidal thoughts and behaviors in adolescents, which is something that we've seen that has obvious public health impact. Certainly all of us are recognize how worried we are when we think that kids are at risk for suicidal thoughts and behaviors. And what we've seen in the last decade or so is that the number of kids who are who have death by suicide has increased in the last decade. We also know that more and more kids in our YRBS studies are reporting suicidal thoughts and behaviors. So this is a really alarming concern, and it's getting worse. And certainly now with the with COVID, there's increasing concern also about sort of these deaths by distress, and there's some, increasing reasons to continue to be worried about suicidal thoughts and behaviors. Of kids who've been hospitalized for suicidal thoughts and behaviors, about a third of them get readmitted, and usually that's happening within the first month or so. So we know that this transition from inpatient to back to home is a really high risk period of time. And so being able to do a better job of thoroughly understanding what's happening that's different for kids who are able to transition successfully versus kids who come back into the inpatient setting is really important. And past research has found some really important factors that seem to be risk factors for readmission, completed suicide, and continued suicidal thoughts and behaviors. And certainly we know, although not everyone who makes a suicide attempt or has death by suicide has a history of childhood trauma, we know that exacerbates it serves as a risk factor, and it also increases the lethality that we see. We also know that family environment serves to be a really important component, and also that that family environment co-occurs with this backdrop of genetic influences that we know. Having family members who have a history of suicide or suicidal thoughts and behaviors places offspring at increased risk as a function of those genetic influences. But one of the things that can be tricky when we think about things like family environment is that most often in research, what we do is a kid shows up after they've been admitted to the hospital or the ED, and we ask them, oh, how supportive is your family? Which of course is going to be incredibly biased, right? Because at that moment that we've asked them, they are being readmitted. So we've got this trickiness around trying to measure factors that are not being, that can only be measured at the same time, and also have a bias involved in them. So when we think about family environment, this is particularly important. This is also, of course, important when we think about childhood trauma. And the other thing that can be complicated when we think about this is what is it that we're measuring when we think about emotion? So when you think about emotion, I'm going to show these 3 red circles. And so maybe I'll back it up a little bit. So the model that I have for what I think may be one integrated way to think about risk for suicidal thoughts and behaviors during that transition period home is that I hypothesize that having a genetic backdrop of risk is going to increase the likelihood that you then are at increased risk. And also having a history of trauma further exacerbates that. And then having a problematic home environment where you are emotionally distressed afterwards. And I think that emotional experience is a really critical part of what we understand in terms of risk. That emotional component, for those of us who have kind of been in clinical settings, we've certainly sat in front of an adolescent and had that experience of this amazingly intense emotion that they're experiencing, that they're in tears and then they're angry, and then, and day to day that might shift quite a bit. A lot of the clinical psychology framework for understanding suicidal thoughts and behaviors, as well as things like non-suicidal thoughts, non-suicidal self-injury, come back to this emotion regulation framework. So how intense is someone's emotion? How quickly do they change? And how long does it take for that emotion to return to baseline? So thinking a little bit more about that, the kids that we might really worry about when they transition home are those kids who sort of can't manage that affect. So they get home, they get in an argument with their parents or with their romantic partner or with their best friend, and they just can't kind of self-regulate. And when I think about that, certainly when we think about this affect regulation piece, we can think about different types of affect, like negative affect or positive affect. We can also think about what I have here, which in this figure, what I have is negative affect plotted against time since stressor. So the damped, there's a framework called the dynamical systems modeling. And dynamical systems models help us to think a little differently about the multiple ways in which things like emotion can function. The damped oscillator model, just to kind of unpack this a little bit, because it's important for the ecological momentary assessment I'm going to describe, that model posits that there could be something, you can actually go ahead and quantify something based on this damped oscillator model. So the way that I think about this is, imagine that you're driving along in your truck and you have a really great shock absorber system. So when you drive along, you hit this bump in the road, and your amazing shock absorber system, you barely feel that bump, and you quickly return to baseline. So you're not kind of bouncing very far. So the intensity of that bounce, the frequency of bounces, and then the return to baseline are rapid. As opposed to, let's say you've got this really junky old truck, you have no functioning shock absorbers, you're driving around, a recent, Grove City, Ohio, and they just fixed the roads and it's kind of a mess, and you hit that bump, and all of a sudden you have this massive intensity of a bump, and you can't return to baseline. It takes longer, and you have a harder time returning to baseline. So the theory here is that we all, by virtue of various factors, may have different sensitivity of our shock absorber system. And that, I believe, is partly genetically determined. That's happening sort of from a heritability level. So my mom or my dad's own affect regulation skills are a function of this, or their shock absorber system. And that also can be impacted by epigenetic changes. And so that is where I think childhood trauma comes into place. So the theory that I have is that particularly when you have these in concert, when you have early trauma that sort of messes with your shock absorber system, when you already have this heritability component that messes with your shock absorber system, and then when you hit that bump, so the bump is getting discharged from inpatient, that this can mean that you have different degrees of difficulty with returning to baseline. And so we wanted to do a better job, though, of measuring how that looks. And by trying to match sort of this theory and this analytic approach alongside ecological momentary assessment. And what's beautiful about ecological momentary assessment, which for those who don't know, the idea here is that your phone will send you a little like text message that says, hey, actually through Illumiview, we'll talk about this in a second, it will alert you to complete a questionnaire. And then you can find out how the person's feeling really in real time at that particular moment in time. And then you can map that over time to try to look at how things change over time whenever we have a time-related question. So this particular study, the goal was to look at distal, so this would be trauma, DNA methylation, and proximal, so these are social context, and I'm going to talk a little bit about how we measure social context, influences on experienced affect. This is, again, something that we are measuring in real time in the moment, and course of suicidal thoughts and behaviors, which we're measuring also in real time and using traditional questionnaire sorts of approaches. Following discharge in teens hospitalized for suicidal thoughts and behaviors. This was a study that we implemented at Bradley Hospital. The kids were recruited from the inpatient unit. They had to be hospitalized for suicidal thoughts and behaviors. We purposefully included kids with all sorts of comorbidities. So they could have substance use, they could have PTSD, they could have any number of concerns as long as they were hospitalized for suicidal thoughts and behaviors. We excluded, though, kids who were primarily admitted for psychosis, autism spectrum, or who had some sort of a language disorder. And you'll see in a moment that the reason for that is because we really wanted to unpack some of the social components that happen after discharge. So we can think about those as treatment targets down the road. This study was implemented in kids 13 to 18 years of age. And we combined the kind of digital approaches that I'm going to talk about with traditional approaches. So we did some clinical interviewing. We used the SITBI, which is an interview of suicidal thoughts and behaviors. We did the CSSRS, also suicide related. We did the clinician administered PTSD scale for children and adolescents, as well as the life events checklist, which goes with that. Those were to measure PTSD and trauma history, and the CASADS, which is a widely used measure to assess affective disorders, anxiety disorders, and a whole host of kind of DSM. This one was the DSM-5. And then we also collected blood samples from the participants, and we have just wrapped up our genome-wide arrays. We're looking at DNA methylation at the moment, and we also will be looking at RNA. So focusing here a little bit on the digital part now, we wanted to do, like I said, a much better job than people have done in the past around really understanding what is happening in that transition as kids go home. We didn't want to just wait until they have trouble and find out later what was going on, because it's incredibly biased. So we had 3 different ways of really trying to do a good job of characterizing kids' social worlds and internal experiences. The first one was ecological momentary assessment. That was the tool that involves Illumivu. We used MIMA platform, and I'll talk a little bit more about each one of these in turn. We also used the electronically activated recorder, which I'll talk about also a little bit later here. And that allows for this brief capture of audio snapshots so that we could go in and code for social context. And then actually, interestingly enough, like many parts of the research that I do, a lot of the work that I do has been informed by my actual clinical experience. And so I was there covering someone's maternity leave on the inpatient unit when we were deploying the study. And it occurred to me as I saw kid after kid after kid and family member after family member after family member talk about their kids' obsession with text messaging and Facebook Messenger and, you know, every tool, Instagram, Snapchat, you name it, that I was going to miss all of this social world if all I relied on was what was audible. And so I submitted a competitive supplement and was able to get some funding to then also look at kids' online social networking behaviors. So we recruited kids at baseline while they were in hospital. We consented them, got a blood sample. We implemented diagnostic interviews, and then followed these kids prospectively for 3 weeks. So we sent them home, literally when they were discharged, we sent them home with a device, an old Moto E phone, and sent them home to go about their day. During that time, they were completing ecological momentary assessments. The ear was recording passively in the background. And then we brought them back in at the 3-week follow-up, at which point we did clinical interviews, we did a timeline follow back. For a subset of participants, we also did the life stress interview and CSSRS, SIPI, some of the different measures of suicidal thoughts and behaviors, diagnostic interviews. We also, at that point, downloaded, for those participants who were that part of the study, their online social networking data from that 3 weeks post-discharge. Then at 6 months, we followed up again with these kids, again, did pretty much replicated the 3-week protocol. So our participants were consistent with the inpatient unit, predominantly Caucasian, but we did have quite a lot of diversity with gender identity and sexual identity. So a number of our participants self-reported transgender, gender identity. We actually asked that question at every single time point, and we had a few participants who self-reported a different gender identity over time, actually. We also had quite a lot of participants who self-identified as sexual identity minorities. Consistent with what you might expect with kids hospitalized for suicidal thoughts and behaviors, the vast majority of our kids met criteria for depressive disorders, but we also had quite a few kids with anxiety disorders, certainly ADHD, some of the other things that we commonly see in kids hospitalized for suicidal thoughts and behaviors. Again, consistent with what you might expect for kids showing up to be hospitalized for suicidal thoughts and behaviors, we had quite a lot of the kids were involved in prior care before ever being admitted. And so now I'm going to focus on the part of the study that has to do with ecological momentary assessment. So we conducted this EMA protocol. Again, it was 3 weeks of time. Kids completed morning and end of day assessments. And then throughout the day, 5 times a day, between 9 a.m. and 11 p.m., there were random prompts. So there were tailored windows, so we didn't end up with any bunching at the beginning of the day or the end of the day. And also they were tailored to be around the kids' school schedule. So we didn't want to ask any EMA questions when they were in the middle of class. We asked, we also had some event samples. So before kids were discharged, we trained them that if they found that if they'd engaged in self-injury, if they had an acute event of feeling an increase in suicidal thoughts, that they were instructed to go ahead and complete an event sample. And then we assessed their thoughts and self-injurious thoughts and behaviors, and also any recent events that might have happened. And I just want to mention, so, a lot of times people don't feel comfortable asking, using ecological momentary assessment, are you thinking about killing yourself right now? So from an IRB perspective, we address that in a couple of different ways. One of them is that although Illumivoo, most people use Illumivoo in a way in which you're collecting data as you go, and it's all being uploaded to the cloud the entire time. In this case, we actually set it up so that we didn't collect the EMA responses until the very end of the study. So that way we never knew in real time if they were at risk. We created a tailored sort of safety pop-up. So if kids did report any suicidal thoughts or behaviors, or non-suicidal self-injury, there was a tailored pop-up that would say, you know, we're concerned about you. Here are the phone numbers of the people you told us you would want to contact when this kind of thing happens, or you can call, you know, and then we had a list of potential phone numbers. So this is a description here of overall what we found for our participants. So over the course of the study, we had more than 6,000 separate assessments occurring. This is both random and event. And a little over, tiny bit over half of our participants reported at least at one point that there had been an event in which they had suicidal thoughts. There were also quite a few participants, about a quarter, who reported at least one occasion in which they engaged in non-suicidal self-injury. So that's like something like cutting, some sort of self-injury without the intent of death. And then we also looked at a variation of the PANIS to try to measure affect over time. And we found that we did have that the mean sort of levels aren't fully capturing things. There's quite a bit of variability over time in positive affect and in negative affect. And this is just to kind of give you guys a sense of what does this look like. So if you look at this figure at the bottom of the screen, what you see is that we have the intensity of affect, and in yellow it's happy, in that bluish color it's sad, and in purple it's angry itself. And what we've plotted is what one particular teen and what they were reporting in terms of their affect every day post-discharge. And then we also have a little, whenever kids do report an event or report suicidal thoughts or behaviors or NSSI, then we go ahead and have a pop-up that asks, like, what's going on, sort of why are you feeling upset, or what precipitated this. And these are actually examples of things that one teen told us in those pop-ups. So one teen said they felt like everybody was asking how they were doing. Another teen said that a friend wasn't supportive. And so now you can map over time someone's emotions at the same time that we're looking at what are the situations that are tied to those emotions. So we are in the midst of getting our data into a space where we can do the dynamical systems modeling. But as we did, we started out with what's called time varying effects modeling. And it's a slightly different approach than the dynamical systems that we are going to be, we're in the midst of prepping our data for. But this gives you a little bit of a sense of what we're finding so far in terms of emotions over time and how that seems to impact the likelihood of kids reporting suicidal ideation in high levels. So what we found was that, and some of these things are kind of not surprising in retrospect, like many parts of science, but having higher levels of negative affect are associated with suicidal ideation, and having higher anger and irritability is associated with, over time, is associated with suicidal ideation. This is mapping in real time how it changes over time, because we asked both. And then, but on the other hand, what we found was that positive affect does seem to be protective. When we look at how does a history of trauma impact that, we did find that there seems to be an impact potentially of a history of trauma. So teens who have a history of emotional abuse were likely to show a higher negative affect that increased over time. And also that there was anger and instability that was sort of low at first and then became higher and moderately stable. So this kind of speaks to my earlier point around how we might think about how early life trauma might impact that stability. So let's see, oh, what happened? Sorry. Okay. So when we think about the ecological momentary assessment, at the same time, we're also thinking, as I mentioned, about what is happening in the social world. So what are some, in addition to that, thinking about this bump in the road as being discharged from inpatient, we can think about the idea that when kids go into certain home environments, they may experience future bumps, right? So it's not like their home environment necessarily is stable. Nobody sort of has an uneventful life after they get discharged, no matter what you're being discharged for. So what we were able to do then is using this combination of ecological momentary assessment along with the ear technology. So the ear, the electronically activated recorder, is a tool that was developed by Matthias Mehl, actually back before, a couple decades ago, actually. And the intent of the ear is to capture these brief audio snapshots of someone's social environment. In our case, we looked at these 30-second audio snapshots captured every 12 minutes. Participants never know if an audio snapshot, if the audio is being captured or not. So at any given moment, probabilistically, we're not actually measuring them. So we explained to participants at the beginning that chances, this is not your way to reach out to someone. Chances are we will never hear what you just said. It's only 5% of the time. But that 5% of the time allows us to go in and manually code, humans go in and code what is happening, what are the social interactions that are unfolding. And then we can map that on to the ecological momentary assessment part of our protocol. So I'm gonna give you an example of an ear audio recording that I put together a while back when I was meeting with my data manager about prepping some data for a talk I was giving.
Oh, so because I am playing at the same time that you'll be working on it, if you could like just save it as something else and call it Final 2 or
like 2.0.
Yeah, that sounds good. Okay. Yeah. Final. No, I'm not kidding anymore. This is it.
I like how there's like JG clean data and then there's like Final clean data. Here's my original clean, or like the real clean. It's not clean.
So you can see that this is just a 30-second snapshot that just happened in the same way that we normally would. She knew, she was fully informed that I was going to be, that the ear was on. But you can see that we could code that in a ton of ways. So we could code that for, was I alone? Was I with someone else? We could code it for content. So we were talking about data. We could code laughter. So there's a ton of data in that one little audio snapshot. And yet it's brief enough. So it's long enough that we can get real coding out of it, but it's brief enough that it doesn't feel like we've now listened to the entirety of someone's day.
Oh, so.
Oops. So I am just going to briefly mention that Matthias Mehl and Deanna Kaplan have actually have some beautiful articles out there that you can review if you're interested to learn a little bit more about the ways that you could actually implement this research in your own research. So one of the parts of the ear involves actually going back in and how is it that you go ahead and code this data. And so I know I don't have a ton of time and I want to get to a lot of stuff, so I'm just briefly going to mention what these are. You can code for who are they talking to, the type of conversation. You can code for affect. So we put a lot of time and energy into creating a robust coding scheme. And And then what you do is you basically go into every single audio file and you create a yes, no for each category. So yes, no, laughing, yes, no, crying. So it's incredibly time consuming. So looking at our audio samples, so this data is the one piece of data collection that's still ongoing. So I'm gonna tell you at the outset that this will change when we get to the publication stage. But so far in the beginning part of our study, we had slightly under half of the time kids were alone. And you can think about alone in two different ways. One is sort of alone, really there's no one else that's audible in the environment. And then one that's, you can hear that like a family member's in another room, but they're not engaging with them. What we saw is that when kids are talking to someone else, they're most often talking to their mom or their friend. But we also captured examples where kids were live chatting or using the phone, where they were talking to their dad or sibling, as well as we actually, believe it or not, do have some examples of kids interacting with their medical providers, which is really interesting. We find that most of the time teens are talking about practical stuff. How am I getting to school? Are you going to pick me up after the basketball game? Whatever it is. A chunk of it is actually small talk. What do you think about the weather today? And then some of it is substantive and involves things like emotional disclosure. Kids are spending a lot of time watching TV. I would love to see if we could do this exact same study all over now after COVID, how all of these different things might change. And what we see though is that kids are spending, if we look across different emotion expressions and behaviors, this genuine laugh is what we hear the most, which is not what I expected given the recruitment sample. So then, the whole point of using the ear is to try to understand how does that then map onto actual risk. And so at follow-up, like I mentioned, we actually ask kids about how they're doing. We do timely follow back, we ask them if they've had suicidal thoughts and behaviors. And so again, we're not done with the ear coding, but I could tell you that kids who reported that they had made an attempt to kill themselves were more likely to have more audio files that showed that they were feeling sad or down. Interestingly enough, we also had more audio files that show that those kids were animated or excited. So I think that'll be really interesting to follow up on in the future when we're done coding. Since we also asked them, since we last saw you, did you engage in any non-suicidal self-injury? In this case, the predictors were that we had coded self-injurious thoughts and behaviors, conversations about it. So kids were talking about it. Also that we had data to suggest the kids were showing conflict or tension, and that they were, again, animated or excited. And then we coded the teens' behaviors and then the parents' behaviors as well. We also coded friend behaviors, but I'm gonna focus on parents at the moment. And what we found is that the kids' behaviors were much better prediction. So we didn't find as much as I expected around the parent behaviors. What we did see is that when we saw more evidence of parents being dismissive or minimizing of their kids, those kids were more likely to engage in non-suicidal self-injury, which fits so beautifully into some of the treatment models we have, like some of the DBT treatment approaches. I know I'm running out of time, so I'm going to so fast just mention that we did this online social networking as well. A colleague of mine in computer sciences, Jeff Wang, has developed this really great tool that has allowed us to pull down data that, with kids' consent, across lots of different platforms. And then we can capture this incredibly rich interaction. So these are actual text message exchanges that our teens had in the course of the study. So you can see just how incredibly rich it is to see what it is that teens are saying back and forth with their friends. I was shocked by actually how much content also gets shared via text messages with parents. So there's some really important data here, and it's, you know, kids are already using it. So from a data burden perspective, it's quite minimal. Just matters, it's just a function of kids being willing to share that data. So when we looked at that data, we found that on days where kids, when we compared kids who on that particular day they reported suicidal ideation versus days where kids were reporting no suicidal ideation, we did see that there were more conflictual interactions where kids were sending messages that were conflictual, where kids were more likely on suicidal ideation days to be sending messages seeking help, seeking support, or providing support as well. They were more likely to report sort of symptoms, and they were less likely to be describing just daily activities, just coordinating, like, can you pick me up? Or, you know, I'm on my way home. And here we also I have some examples of what those can look like. When it comes to received messages, we see that it's the conflict, that conflict, support, and symptoms are also, these are the predictors. And I think it's interesting to see that the messages that come into the teen around their friends or family members' symptoms are actually a predictor of the kid's own increases in suicidal ideation. So we're going to try to summarize all of this together, this multi-method approach to really characterizing how kids are doing. What I would say is that we can measure kids' behaviors in the course of post-discharge in a really high-risk sample, and that it does seem to be predictive. Some of these measures that these behaviors that we're measuring, they do predict subsequent suicidal ideation. When we think about what does this mean, how would we integrate that into therapy, or what are the kind of major lessons learned? It seems that the teen's positive affect is associated with lower SITB, self-injurious thoughts and behaviors, and that OSN, kind of used to coordinate activities, online social networking, was increased on SI-free days. So this actually, again, fits so nicely with our treatment model. So if I were going to turn that into treatment model, I would say, kind of that classic behavioral approach around behavioral activation. So helping kids plan something, do something that's going to increase their positive affect. It's not just negative affect, it's negative affect without any positive affect. What we see also is that, that said, that we do see that negative affect, anger, irritability, those are impacting suicidal ideation, feelings. When we see data from a teen, when we hear them and we code them as seeming sad or down, talking about self-injurious thoughts and behaviors, seeming that there's a lot of conflict, this again is, these are negative indicators. And then when we think about online social networking, we see that teens are having more conflict, they're seeking help, they're seeking support, and then there are symptoms involved. We also know that although it seems like the biggest predictors were on the teens end, we do, based on this data, we do have data to support that your social environment does have an impact, that they can help to buffer some of those negative impacts. And they can also exacerbate things. So things like dismissing or minimizing or having peers who are relying too much on you for support, those things can be increase a teen's risk. So the next steps, I mentioned that we're wrapping up our EAR coding now. We're wrapping up our GWAS and EWAS. As I mentioned, we're working on dynamical systems modeling. We also have a ton of new ways of thinking about understanding the rich ear and OSN data that we have. So if I were going to say, like, what's kind of a pro tip you might have, I think the kind of outcome I would draw from some of this is that online social networking can be problematic, but it's not all bad. So it can be a supportive context. We see teens middle of the night text messaging their friends at a time where they would never have access to a clinician or a parent. So and receiving support. So I think there can be some good things. As I alluded to, behavioral activation works. And, you know, as I have said for many years in therapy, validate. If somebody is telling you how they're feeling, do not dismiss them. So I have had over the years the most amazing research labs, and it takes really like a huge army of people to collect this data, to analyze this data. And I'm incredibly grateful, and I feel guilty for all of the hard work. But I'm incredibly grateful for this incredible team of people that I've had over the last 5 years. And also for the intellectual contributions. So Michael Army is my ecological momentary assessment expert, and there's no way we could have measured things, I think, as carefully as we did here had it not been for his involvement. I mentioned Matthias Mehl and his expertise related to the ear. Jeff, my computer science colleague, has been the online social networking component of our study never could have happened. And certainly, I'm so grateful for NIMH for deciding to fund this research. So thank you all for letting me present some of this work to you. I'm happy to entertain questions now. And also here you'll see this is my contact information. So if you have questions down the road, like I said, a lot of this data is going to be coming out in the next couple of months, certainly years over time. So you can stay tuned, but I'm also more than happy to have some emails with folks.
Thank you so much, Nicole. That was a lot of information. I know you tried to pack it in there. We do have a couple of questions, actually, seems like specifically about the ear. Yeah. There's one from Alyssa. Alyssa, would you like to ask your question?
Sure. Thank you for a great presentation. This is really, really fascinating. I was wondering, on average, how many ear snapshots you got in a day, and if you got any pushback from adolescents about recording their data or their text messages, and how you dealt with those issues.
Yeah. So one of the things that we do so the standard methodology for ear that Matthias Mehl has developed is this idea that a big part of that first consenting process is us kind of explaining to families, we only want you to share with us the data you feel comfortable sharing. We are partners in this research. And so if there's anything that you don't feel comfortable sharing, we have them complete this sort of daily diary, and they can mark out periods of time that they want us to delete those files. In adult research, what usually happens also is when you hand over the ear audio samples, you now have the opportunity to listen to them. So you can actually sit down and listen to every single one of those audio snapshots if you want, and pick and choose if you don't want some of them kept. From an IRB perspective and an ethical perspective, I chose not to do that for adolescents. And the reason for that is because I couldn't be 100% confident that parents wouldn't say, I want to listen to those files. And so because these kids are minors, I had some concerns about what that could look like. So I didn't give people the option at all of listening to their audio files in the case of the ear data. But I did tell them that they could delete data. They could tell me in real time, so they could fill out this form that they were supposed to be filling out. But like adolescents, sometimes they don't. So we could also ask them later on if they wanted us to delete any files, and of course we did. in the 79 participants that we had 2 participants who wanted only a couple of data files deleted. It's insane. Like, I mean, part of the context, I think, here, and that the ear part of it actually is really, Matthias has been doing this for years, and he finds the same thing in adults. I think it's more extreme in teens because they're just used to, like, the world exists in this like reality TV show / online. So I've been surprised by how willing kids are to share this data. We will, when we publish, and even in these slides, everything is reworded a little bit. So you could never go back and figure out who this was. This, because it's an NIMH study, of course, and it involves genetics, we are going to do data sharing for the genotype, but we are not going to do data sharing with any of the ear audio files. Like, none of that is available to anyone. So by the time any of that data comes out, it's all fully de-identified, like what you saw here.
Great.
Thank you. And Deborah, I know you had a similar question about the ear. Did that answer it for you, or do you have any more?
No, I think you covered partly some of that, the question. I just wonder, from the IRB perspective and the consent, do you consent the whole family, given a lot of those recordings probably more family centered?
Yeah.
Okay.
So what we do, a lot of how I think the IRB can feel comfortable with this is because we spend a lot of time consenting kids, training kids. So we unpack for them. So their device that sent home with has like a little sticker on it that shows like a little microphone, and they're supposed to keep it with them, and they're supposed to, when they interact with a new person, explain to them, you might be recorded. I'm in this study. Actually, we have a couple examples of kids kind of like making jokes and saying like, oh, they could be listening to us right now. So in fact, kids are at least some of the time telling friends, for example, in advance that they could be recorded. So that's part of it, is that the teens, the responsibilities on the teens to then share. Parents are consenting for their kids' involvement. Parents also consent for their own involvement, although we don't give them an ear as well. And then the other thing to consider with ear research is that there are different rules about recording in different states. So Rhode Island is a single party consent state, which means that technically speaking, I could record whatever I want and never tell you. So as long as I have consented. But there are other states where it's a 2-party consent state. So like Massachusetts is a 2-party consent state. So I can't record unless both people have consented to that recording. So that makes ear research a little complicated in different states. The way that Matthias has handled that differs a lot based on your respective IRBs. So the easiest situation is one like I'm in, but he has also done it in California, like literally all over the globe. And they have a number of different ways of handling that, that range from just making sure everybody's clear that everybody's consented to actually some ways that the ear app can be modified to distort voices around recognition. So I don't know if that hopefully answers your question.
Thank you, Nicole. Yeah, I have a question too, but I just want to pause, and if anyone else has a question, please feel free to jump in now. You can unmute yourself and jump in. Yeah, Young Wei.
Yeah, so I think this is a wonderful study, and you collect a tremendous amount of voice samples. So I'm just curious, have the participants consented for these voice samples to be used beyond this research, for other kind of research topic related, but
right. So like, do you mean, maybe you can unpack that more?
I just want to, you can send these participants to do the study and to wear the device to collect their voice sample periodically. Are they did they give you kind of general consent to use these voice samples beyond just what you specified in this research study?
Not outside of like looking at suicidal thoughts and behaviors and you know, trauma and stress. Like, it's pretty broad. So for example, in Matthias's research, he does have some examples where he's got multiple different studies that have used the ear, and then because of the way the IRB is written, they're able to then kind of cobble those together and look at questions like they've looked at males versus female, women versus men. Are they talking differently? Like, do they have a different style of talking? And so we can combine that. In this case, because they're minors, we kept it relatively narrow, but within that, there's, you know, there's degrees of narrow, right? So anything that's sort of very specific to this research question, we could ask. The other thing that I did do is get consent for recontacting. So in the future,
nice.
Hopefully there'll be opportunities to follow these kids again.
So a kind of related question, you mentioned about its tremendous effort to code these voice samples, right, for different you know, themes you're trying to capture. Have you looked into kind of automate some of the coding effort? And that's why I kind of asked about the voice sample, whether you can use it for kind of looking at automation of the coding part.
Yes, that is the next plan, actually. So my hope is in the future to submit a grant to look at can we automate some of this, given that we did put all that hard work into going ahead and manually coding. Are there ways that we could use that audio data to mark indicators of risk that wouldn't require audio recording? And then you can imagine that the downstream implications of that. So wouldn't it be so fabulous if you could have an app on your phone that sort of like identifies a moment in which you're having an argument, or it seems that the kid is distressed, and it could, you know, there could be like a pop-up that says, you know, use your DBT skills, or, you know, we're worried about you, you might want to call and have an appointment with your psychologist. I mean, you can think about all of the implications in terms of intervention would be massive if we could, you know, have that happen much more quickly than, you know, waiting for the painstaking coding.
Yeah, thank you, Youngwei. Any other questions? I'm going to sneak my question in then, Nicole, before we end, which is coming from a technology perspective. Like, I'm hearing, you know, using all these different really innovative ways of collecting data and then trying to figure out how to put them all together. I'm curious what like your big vision is. Like, if money and technology wasn't a problem, like how would you, what would be the digital methods you'd want to use?
So, you're right. I mean, right now, the way that we're approaching it is that we've got these multiple streams of data that then, from a data management perspective, we have to clean. And then eventually we put them, we sort of come up with timestamps and we put them in, you know, time sequence. And so that is very intensive on the data management side. And so, and it doesn't lend itself to sort of a just-in-time adaptive intervention kind of thing, which I think is the ultimate dream. Anytime we're describing, we want to be eventually getting towards intervention. And so, you know, what would be fabulous is if there was a way to kind of be looking at all of these things in one, you know, if there was an app that could merge all of them so that we're not having to later on do the time stamping. And, you know, from a data perspective as well, we go in and we code. We have to upload each audio file. We do it in RedCap. We have to upload each audio file and then code each audio file. And it's like super time intensive. If there were some mechanism of all of those things kind of being pulled into some data system at once, that would be pretty magical.
Yes. Yes. Let's see what we can do about that.
If you want to do the like back end data too, for, you know, the dynamical system modeling, time, you know, the time varying effects models.
Yeah, absolutely.
That'd be awesome.
I think there's a lot that can be done. Thank you so much, Nicole, for your taking the time to go through this with us all. And thank you all for joining us. As Youngwei said, we have another one of these on July 28th. We'll be talking with Andreas Schmidt, who's at one of the major diabetes centers in Germany. He's going to be telling about his work. We will be providing the recording of this call. We'll send it to all of those people who are registered. So all of you and anyone who didn't make it, feel free to share it. And we look forward to hopefully seeing you back here in a month or so. Thank you, everybody.
Thank you.
Nicole.
Thank you, Kat and
Be
Nicole.
well, everyone. Stay safe.
Bye.
Thanks.